presenting on two topics. So she will be presenting on urinary tract cytology and serous fluid cytopathology, but we'll have a break for Q&A in between those two sessions. So I'd like to open the meeting with Dr. Smart's presentation. Thank you.
Good morning, everyone. My topic today is avoiding the pitfalls in urine and serous fluid cytology. As they're very different samples, I'd like to talk about them separately. However, what they both have in common is that they have reporting systems fairly recently published, and I hope to emphasise how these systems can perhaps help us avoid some of the pitfalls. I'll start with avoiding the pitfalls in urine cytology, and can the PARIS system help? Just to recap, the indications for urine cytology are the investigation of suspected urinary tract neoplasia, in particular the detection of high-grade urothelial cancers. We can also use urine cytology to detect recurrences after treatment, but have to bear in mind that urine cytology is of limited value in the detection of low-grade urothelial cancers. So what are the challenges and pitfalls in urine cytology? Well, basically, it's when we either over-interpret the cells as abnormal, and there are several mimics of neoplasia, or, on the other hand, that we under-interpret the abnormal cells that are present. Ways in which we can avoid some of these pitfalls, which I'll expand on throughout the talk, are to know the type of sample you're dealing with, be aware of the limitations of urine cytology, especially with low-grade abnormalities, pay very close attention to the morphological features, applying the PARIS criteria when required, be knowledgeable about the common mimics of malignancy, and, if available, use ancillary testing in tricky cases. All these aspects are incorporated into the PARIS system, published in book form in 2016. It's important to know whether you're dealing with a voided or instrumented sample or a catheter specimen, and that's because the cellularity does vary between the specimen types. Instrumented samples are often much more cellular than voided samples, for example, and each also has different architectural features. Voided urine will consist mostly of dispersed single squamous and urothelial cells, whereas in instrumented samples, clusters are common. Catheter samples can be very degenerate. The PARIS system, however, applies to all sample types. The PARIS system has 7 diagnostic categories: non-diagnostic, negative for high-grade urothelial carcinoma, atypical urothelial cells, suspicious for high-grade urothelial carcinoma, high-grade urothelial carcinoma. There's also a category for low-grade urothelial neoplasia and one for other malignancies, which may be primary or metastatic. And as you can see, the emphasis of the PARIS system is very much on determining whether a sample is negative or positive for high-grade urothelial carcinoma, recognising that urine cytology is just not good at detecting low-grade neoplasia. The PARIS system includes standardised criteria based on nuclear features, and these criteria are the same across all sample types. The PARIS system clarifies the benign nature of architectural tissue fragments and clusters, provided there's no cytological abnormality. It also gives a definite definition for atypia and stresses that minor and reactive changes where a cause is present should be called negative for high-grade urothelial carcinoma. So negative for high-grade urothelial carcinoma is a situation where you have non-degenerated urothelial cells. They're often single urothelial cells or squamous cells and glandular cells. You can also have benign tissue fragments, cell groups and clusters, but the cells present show no deep hyperchromatic nuclei, and the nuclear to cytoplasmic ratio should be less than 0.5, although basal cells do have a relatively higher nuclear to cytoplasmic ratio. So coming back to the pitfalls in urine cytology, when can we make the mistake of over-interpreting the features? Well, the common mimics of malignancy are when we've got degenerate cells, instrumented samples with lots of clusters, reactive changes often due to infection or renal calculi, the presence of normal cells, which can be tricky, including basal cells and seminal vesicle cells, infection with polyomavirus, and treatments changes due to BCG and chemotherapy. The Paris system, however, clarifies that all these overestimate situations can be called negative for high-grade urothelial carcinoma and not atypical. Degenerate samples are very common and can be quite tricky. You can often identify a sample as degenerate because there will be these singly dispersed cells with large red intracytoplasmic inclusions. However, degenerate cells can also present as small clusters with hyperchromatic, very crinkly nuclei, and some of the cells have vacuolated cytoplasm. So it's probably reasonable not to try too hard if you have a sample where the quality is compromised due to extensive degenerative changes, contaminant microbes or bacteria, or where the cells are obscured by blood and inflammatory exudate. Just focus on the viable cells, and unless there's abnormal cells present, call the sample either unsatisfactory, depending on the quality, or negative. Instrumented samples can also be a potential pitfall. An instrumented sample is any sample where the cells have been dislodged by force, including catheter samples, bladder washings, cystoscopic brushings of the bladder, ureter, renal pelvis, and also post-cystoscopy samples. Often with instrumented samples, especially those from the upper urinary tract, they can be very exuberant looking. There can be papillary clusters, fragments of cells lacking in fibrovascular cores. Also, the single cells present are quite often elongated with very tapering morphology, the so-called circariform intermediate cells. But the cells in a negative sample will retain uniform nuclei and even chromatin. And it's not the architecture, but the diagnosis of neoplasia must rest on the abnormalities of that chromatin and the nuclear membrane. And here is an instrumented sample, and this picture is actually taken from the Paris system book, and you can see the variety of cells here, and that you have clusters of cells, smaller, less mature cells, but there's also superficial cells here, and the rather tapered, elongated circariform cells. You can see too in these pictures here how the cells can form these clusters and groups and fragments, and that is a normal finding in an instrumented sample. And sometimes the cells can look quite columnar, as we have here in this picture. And here again we have a cell group and a rather exuberant cluster, but pay attention to the nuclei. The nuclear to cytoplasmic ratio is less than 0.5, and the cells have regular polarity, round nuclei with fairly even chromatin. In this case, the patient had chronic inflammation on biopsy. And here's another instrumented sample with numerous very dark, thick, three-dimensional clusters. At high power, however, we can see that the nuclear to cytoplasmic ratio certainly here is not so high, and the cells have fairly regular, even chromatin. It's impossible to be sure if this is from a low-grade neoplasm, but it is negative for high-grade urothelial carcinoma. And in actual fact, this case also only had inflammation on biopsy. The other situation where you can fall into pitfalls of reporting are when there are quite florid reactive changes. And the Paris system makes it quite clear that reactive changes should be called negative for high-grade urothelial carcinoma and not atypical. When there is marked inflammation, you quite often get quite florid changes, and the superficial cells umbrella cells can look quite bizarre, but superficial mature cells are generally benign, and we really should not use atypia in this setting. Often we need to look for a cause. Are there organisms or are there calculi present? And that would explain the changes, and therefore the sample can be called negative. Renal calculi are a not uncommon cause of cellular changes in urine samples, and especially in voided urine samples, they can present as numerous papillary clusters where the nuclei do look a bit larger. However, looking closely, they should have smooth nuclear borders and only small nucleoli. The chromatin should be evenly dispersed. Another feature that you can find with renal calculi is the presence of squamous metaplasia, and sometimes do see enucleated squames. The history, however, will help avoiding this pitfall. Here's another fragment in avoided urine, and I just put this in because there's numerous eosinophils here, and actually they can be quite easy to miss, especially on a thin prep type preparation. Ileal conduit samples can also be very problematic, but the history of a previous cystectomy is hugely helpful. They include, as well as urothelial cells, of course, degenerate intestinal epithelium, bacteria and other intestinal contents. That means the samples always look fairly atypical, and therefore the threshold for suspicion of malignancy should be set high. Power 1, you can see just this grubby background here. There's some urothelial cells there and some probable vacuolated cells, and there's mucinous material in the background as well, in keeping with intestinal type cellular material. This, however, is an ileal conduit sample in which there actually are malignant cells, and again you apply the Paris criteria: high nuclear to cytoplasmic ratio, irregular nuclear outlines, and coarse hyperchromatic chromatin. Structures can sometimes be seen in ileal conduit samples as well. These are guar cells, which are plant cells from guar gum used in stoma attachments, and definitely should not be confused with abnormal cells. You can see that they're much larger, so shouldn't really pose a problem. Some other cells present in urinary samples can pose a problem and be a pitfall in interpreting urine cytology specimens. Urinal tubule cells, for example, they are often quite small cells, but they have very dark hyperchromatic but degenerate nuclei, indistinct cytoplasmic borders, and rather granular cytoplasm. Seminal vesicle cells can also be a bit of a pitfall. These are often very large cells with large nuclei, hyperchromatic but rather smudgy chromatin. The cytoplasm is quite often indistinct and degenerate, but where you do see cytoplasm, a clue to the fact they're seminal vesicle cells is the presence of lipofuscin. Also, in addition, you quite often see sperm in the background, which would be a clue to the seminal vesicle nature of these cells. Another potential pitfall is confusing schistosomes and uric acid crystals. We can see here that the schistosoma ova are large. They've got a translucent shell and a terminal spine. We can sometimes see larvae within the ova, or alternatively non-viable or calcified ova, sometimes also seen in urine. Uric acid crystals, on the other hand, are smaller, they're featureless, and they polarize. And just incidentally, this lovely picture can be purchased online for £15.90 to decorate your bathroom. Another well-known but nevertheless common pitfall are the decoy cells of polyoma virus infection. Of course, a clinical history of a renal transplant is very helpful. You see the urothelial cells have large intranuclear inclusions, which are basophilic. And you can see a high power, rather homogeneous, structureless chromatin. Sometimes it has a spidery appearance. On the subject of organisms, beware not to attribute any significance to fungal contaminants, especially if these are large, bizarre-shaped fragments and there's a lack of an inflammatory reaction. Iatrogenic changes can cause problems in urine cytology. Samples post-BCG therapy are commonly received in some labs, BCG therapy induces quite a severe reaction around about 4 to 6 weeks with inflammatory changes. Sometimes that's granulomatous, and the urothelial cells can show quite marked reactive atypia. Therefore, it's important to avoid urine cytology immediately following BCG treatment. The samples that you get 6 months down the line are like this, quite grubby, quite degenerate with reactive changes. So that's what you expect in these type of samples. As we see in the cervix, radiotherapy can cause changes to cells in the urothelial tract as well. Often the cells have very bizarre nuclear and cytoplasmic enlargement. The nuclei can have vacuoles and the cytoplasm can be abundant. I hadn't seen urine with radiotherapy changes for ages until about last week when this one turned up, and the cells were huge with big nuclei, but nevertheless a very low normal nuclear to cytoplasmic ratio. The history of previous radiotherapy is very helpful in this situation to avoid this pitfall. I have to admit I've rarely seen chemotherapy effects in a urine, but the nephrotoxicity is characterised by the presence of casts. The cells can be quite tricky with nuclear enlargement. It can be hyperchromatic with an increased nuclear to cytoplasmic ratio. A history would be helpful in avoiding any overcall, and ancillary testing may be required. As I mentioned earlier, the Paris system includes a category AUC, or atypical urothelial cells. Using this category can actually avoid both overcall and undercall, but it should be used sparingly and only when the criteria are met. Criteria are that the cells show mild to moderate cytological atypia, they should be non-superficial and non-degenerated cells, and they should have a nuclear to cytoplasmic ratio which is greater than 0.5. That's a mandatory requirement for the cells to be called atypical, and they should also have one of the following: nuclear hyperchromasia, irregular coarse clump chromatin, and irregular nuclear membranes. Talking about overestimation, it's very interesting that cytologists often overestimate the nuclear to cytoplasmic ratio, and this picture here is quite frightening. It's from Eva Wojcik, and it just shows that a nuclear to cytoplasmic ratio of 0.5 actually looks quite high, and 0.7, which is a criteria for high-grade urothelial carcinoma, is really filling up most of the cell in terms of its area. So, having covered the main mimics of abnormal cells now, let's change to the other situation in urine cytology where abnormal cells can be underestimated or missed, and identifying malignancy can actually be quite difficult, especially when you've got a small number of abnormal cells, or if the malignant cells are present in a compromised sample, such as the ileal conduit one I showed earlier, where malignant cells are actually undergoing degeneration, and that's pretty frequent, where malignant cells don't play the game and they've got either pale nuclei or a low nuclear to cytoplasmic ratio. And of course, identifying low-grade neoplasia is very challenging in urine cytology. When assessing cells in these situations, it's important really to pay attention to the nuclei in helping to determine whether or not they are abnormal, but sometimes you may need to resort to ancillary testing such as FISH to assess the cells. So you can have very few abnormal cells in a urine sample, but the Paris system has a category that if you've only got, say, 5 to 10 cells, you think they look malignant, but you're not absolutely sure, then you can call it suspicious for high-grade urothelial carcinoma. Classification system has a definition for suspicious, where you've got only a few cells, as I mentioned. These cells must be non-degenerate cells, and they must have a high nuclear to cytoplasmic ratio greater than 0.7. They must also be hyperchromatic compared to the cells around, and have at least one of the other features of irregular coarse clump chromatin or irregular nuclear membranes. And here we have another situation where we can underestimate cells, and that's where you're dealing with a more tricky specimen type. And instrumented samples where you've got clusters anyway can actually be quite difficult sometimes to determine if the cells are malignant. But again, it's back to assessing the nuclei. Is it a high nuclear to cytoplasmic ratio, hyperchromasia, coarse chromatin, and irregular nuclear margins, as in this case? Again, we can see at high power, when we concentrate on the cells, concentrate on the nuclear features, they fulfill criteria for high-grade urothelial carcinoma. If you want to find pitfalls, I would recommend going to your teaching file. Here's an interesting case which was in the teaching file because it was heavily contaminated by sperm, and therefore it was reported as cells present of uncertain significance. Could they be seminal vesicle cells? But actually, if we have a look at these cells, they have a very high nuclear to cytoplasmic ratio, coarse chromatin, and hyperchromasia. And in fact, in the case was from someone who actually had high-grade urothelial carcinoma. Unfortunately, malignant voided samples are often fairly degenerate, and in order to avoid missing malignant cells, especially if there's a history, it's important to look for some more viable material. You can see here this very large cell looks abnormal, but it's not very well preserved. Elsewhere in the slide, however, here's a cluster of more viable nuclei which are hyperchromatic and irregular and fulfill criteria for high-grade urothelial carcinoma. Another situation where it can be a pitfall is where the malignant cells have rather pale vesicular hypochromatic nuclei. The parasystem stresses nuclear hyperchromasia, but that's really in the sort of situation where you're not so sure about the cells. Here we have obviously very large, very irregular, but pale nuclei, and nevertheless are malignant. Then sometimes when urothelial cells are malignant, they may not have the high nuclear to cytoplasmic ratio. They may have abundant cytoplasm, but nevertheless, looking at the nuclear features, hyperchromatic, very irregular, prominent nucleoli, malignant looking cells, despite the NC rate. Here again, we've got cells with fairly abundant cytoplasm, but nevertheless, malignant nuclei. So in summary, I suppose, using
Hello, everyone. I think there may be an issue now with that video. It seems to have stopped there. I don't know whether, Christian, is there anything you can do for that? Sorry.
I'll stop sharing, Alison, and then maybe see if I can get back to that slide, which may be easier said than done, but I'll try, okay? I'll stop sharing and then start sharing again. All right, just seen in chat that someone said it's back now. So
oh, great. Okay.
I'll just try again. Sorry.
the Paris system and the NC ratio, it's best where you've got only a low number of cells that are possibly atypical or possibly suspicious. But if the cells look malignant, then they are malignant, even although they don't necessarily have the classic criteria. I'll mention briefly low-grade urothelial neoplasia. Unfortunately, neoplastic urothelial cells resemble normal urothelial cells if they're low grade. They can be more cohesive than the high grade neoplasms and therefore exfoliate less readily into the urine. So as a result, urine cytology has a very low sensitivity for low grade neoplasia. And that is why we're focusing in urine cytology on high grade abnormalities. The Paris system, however, does provide criteria for low-grade urothelial neoplasia. We can make a definite diagnosis only if there are three-dimensional cellular papillary clusters present, and these should have fibrovascular cores with capillaries. If you've got a very cellular voided urine with numerous 3D clusters, increased monotonous single cells, you could suggest low-grade urothelial neoplasia, but should report the sample as negative for high-grade urothelial carcinoma. Other features that support that there may be an underlying low-grade urothelial neoplasm is if there's cytoplasmic homogeneity, a high NC ratio, or irregular nuclear membranes. This is another case from our teaching file, which was sent to the lab as a voided urine, but was put in the teaching file as probably representing an instrumented sample because of all the clusters. This was a case from someone with a grade 1 papillary urothelial carcinoma, and because we didn't believe or know our specimen properly, then we perhaps underestimated the clusters that were present. Just finally, don't forget that not everything in urine cytology samples is urothelial, and we must remember the non-urothelial malignancies, in particular squamous carcinoma and adenocarcinoma. They can occur in their pure forms or be areas of differentiation within a urothelial neoplasm. And this is an example here of squamous carcinoma, which is characterized by these long, tapering, keratinizing cells. Sometimes you can get cells from prostatic and endometrial adenocarcinoma in urine samples, but of course you would need immunocytochemistry in order to correctly diagnose those. Very rarely, lymphoma and melanoma can occur in urine samples as well. And of course, to avoid pitfalls, always be alert to the unexpected. This is a urine from a 75-year-old man, and we can see it's rather busy with these cells with a very high nuclear to cytoplasmic ratio. They're quite small at the nuclear.
That's the sound gone again, I think.
Yeah, I think so there, Louise.
Let me try to just come out again and just start that up. It should start from the same place.
Louise, I don't know whether you could talk to the slides if we. I know it's on a slideshow though.
Sure. Yeah.
Do a summary.
This case from a 75-year-old man, and you can see these smallish cells, very hyperchromatic nuclei and minimal cytoplasm.
Louise, it seems as if the sound's back, people are saying.
Okay. That's me talking. So if you just move on to the next slide, Christian, if you can.
Very hyperchromatic.
Oh, that's it back.
Luckily for us, he had a known history of neuroendocrine carcinoma of the bladder. You can see here at high power these typical cells, which are positive with neuroendocrine markers. Then, to avoid the pitfalls in urine cytology, be familiar with the sample type you're dealing with. Be aware of the limitations of urine cytology, especially with low-grade abnormalities. Pay close attention to the cytomorphology, applying the Paris system criteria when relevant. Make sure you can recognise the common mimics of abnormality, and if available to you, there's always the option of ancillary testing. I think the Paris system book is useful as it covers all these above aspects, and I would imagine that with experience of cytologists applying the criteria in practice, it will evolve and be updated. Thank you.
Thanks, Louise, and apologies for the difficulty in the connection during that. That's probably a technical issue through our platform at the moment. I do have a question, Louise, that's come in. What is your opinion on taking separate samples from the upper urinary tract, such as lower versus mid versus upper ureter, as this seems to be standard of practice in some centres in Europe?
Well, I don't have a huge opinion on it. We do sometimes get samples from the left and the right ureter, and maybe from the renal pelvis, either left or right, if the urologist doesn't really know or can't see anything. I'm assuming these would have to be brushing specimens in order to try and localize any abnormality. I don't know if anyone else, Ash, do you get these multiple samples?
Louise, thank you so much for asking me to comment. Great talk, and apologies for the couple of hiccups, but I think we've got past those very swiftly. So yeah, actually that's a great question, because the differential sampling in the upper tract can be sometimes the only way of localizing where the abnormal cells, say in voided urine, might be coming from. So, you know, if they are suspected to be coming from the upper tract, then the way to collect samples would be, you know, to send them in separate pots from both the left and the right, from the renal pelvis, from the upper, mid and lower ureters. And that can sometimes just explain, in the absence of an obvious radiological abnormality in particular. So it's not a very common specimen type, but as I think has been commented in the chat box there, but Yvonne, there are many centers in Europe where the urologists are sending these samples. Yeah, so yeah, we've had a few of these, but not that many. Yeah, but yeah, it would help explain where the cells are coming from. Thank you.
Certainly, we have had left and right, you know, in these very difficult cases where just can't work out the origin. I see there's a question in the chat about Eurovision fish. I didn't mention about it in my talk because we have no availability to do that. I know there are some centres in the UK. Again, Ash, I think you've got experience of using it, but certainly I don't think it's widely used in Scotland. I'm not sure about elsewhere in the UK.
Yeah, thank you so much again. Yes, we have been using Eurovision fish for about 10 years or so at Guy's and St. Thomas's, and I see the questions coming from Glenn from HCA in London, and you know, HCA also have access to Eurovision fish, you know, being available at I think one or two other centres in London, but yes, not a very widespread available test. It is helpful in cases of atypical urine cytology, where a clinical algorithm is, if you send a thin prep slide to the cytogenetics laboratory and they use this, you know, cocktail of 4 probes, which represents the different sort of genetic abnormalities that urothelial high-grade and low-grade carcinomas can be associated with. And if any of those show an abnormality in up to 4 cells, then the test is read as a positive test. And the clinicians will then follow these patients up more closely if the test is reported as positive, because it's a genetic test and it sort of predates sometimes the appearance of a morphological abnormality in the urinary tract. So Dr. Urina Miki, my colleague, had published a paper a few years ago in Cytopathology where we'd presented our data, and all the patients who went, who had a positive Eurovision fish test following urine atypical cytology went on to develop tumors, either low grade or high grade, over a follow-up period of 2 years. So It is a test worth considering, but it is limited because it requires fluorescence microscopy. It requires a senior biomedical scientist to read the test. But if there's a functioning cytogenetics laboratory where you're working, there's no reason why it can't be incorporated into the workflow. And incidentally, we also use Eurovision FISH for our biliary brushings as well, the atypical ones, where again, there's a similar sort of algorithm followed. So
I think it's
question.
I think it's one of these kind of tests that if you don't have it, you probably don't miss it, but once it's available, you will find lots of atypical urothelial cells you really just want to get to the bottom of.
That's brilliant, and thank you for those questions and comments. I'm just conscious of time now, so I think we'll move on to Louise's next presentation, which is on serous fluid cytopathology.
The second part of my talk is on pitfalls in serous fluid cytology and can the international system for serous fluid cytopathology help? Fusions are common and certainly comprise a significant component of many cytology labs. Workload. The preparations are under laboratory control as the samples generally come in a pot, which is useful. Serous fluids play a role in diagnosing the causes of effusions, but also in staging of known cancers. With serous fluids, however, there's many different diseases to consider and many cell types, including mesothelial cells, epithelial cells, lymphoid cells, and there's also an overlap of morphological features. This means that immunocytochemistry is often central to malignant diagnosis, and we need to have knowledge of both morphology and ancillary testing in diagnosing serous efflusion lesions. As a result, we're not short of challenges and pitfalls in serous fluid cytology reporting. These include interpreting mesothelial cells. Are they benign reactive versus mesothelioma? Are we dealing with mesothelioma or adenocarcinoma when we've got samples with clusters and single cells? Interpreting ancillary tests is not without its challenges sometimes, as are low cellularity samples. There are also specific challenges in certain scenarios, including lymphocyte-rich samples, gynecological washings, and gastrointestinal pathology. To avoid some of these pitfalls, knowing the clinical history can be extremely helpful. When assessing the slides, it's important to know the sample type, pericardial versus pleural fluid, for instance. To look at the morphology, we need to consider the architectural patterns and pay close attention to nuclear features, and assess morphology often in conjunction with immunocytochemistry. We could refer to the various chapters of the international system and the information provided, including some of the algorithms to help us sort out the cellular problems. But it's really important also to be aware of the range of appearances that can occur with various malignancies in serous fluid, and I think there's no substitute for experience and seeing as many cases as possible. The international system applies to fluids in the pleural, pericardial and peritoneal cavities. There are 5 diagnostic categories: non-diagnostic, negative for malignancy, atypical of undetermined significance or AUS, suspicious of malignancy, and malignant. And malignant is divided into primary and secondary. The international system provides definitions and an implied risk of malignancy, together with recommendations for management for each of those categories. It suggests that the indeterminate categories, AUS and SFM, can be used in preliminary reports or possibly as options of last resort. The TIS emphasises the role of ancillary tests in reaching correct interpretation and the importance of reaching a definite diagnosis. The International System book, however, contains much more. There are specific sections on adequacy, ancillary studies, the diagnosis of mesothelioma, considerations for peritoneal washing specimens, cytopreparatory techniques, quality management, and also anatomy and physiology. Let's look at the potential pitfalls in more detail, starting with mesothelial cells. In peritoneal washings, we're all familiar with the nice regular fat sheets with distinct cell borders that characterise the mesothelial cells. They can, however, look quite squamoid. And this is a washing sample from a 72-year-old with benign serous cystadenoma and pelvic inflammation. And the washings had a rather grubby background to them. And you can see that in the sheets of mesothelial cells, the nuclei have a very interesting lobating appearance. And this lobated appearance is the so-called daisy cells. It's a benign reactive phenomenon. Sometimes too, mesothelial cells in peritoneal washings can be multinucleated, adopting this Teuton-like ring appearance. And of course, lovely pretty collagen balls can also be seen in peritoneal washings, the mesothelial cells wrapping around a collagen core, representing the detached papillary tufts, and not to be confused with glandular clusters. Benign mesothelial cells in ascitic fluid, however, look different to those in the washings and can present pitfalls, particularly in reactive effusions. Reactive effusions can be cellular, but they should not really be supercellular. Often the clusters are quite small and the windows between the mesothelial cells obvious. There may be some nuclear variation, but the nuclei should not be too large and probably no more than 2 times the size of a neutrophil. Binucleation is common, and as is multinucleation, and polymorphous population can sometimes also show mitotic activity. Reactive ascitic fluid samples with mesothelial cells can be challenging and a bit of a pitfall, particularly if they're forming these papillary clusters on a background of inflammatory cells. They stand out looking like glandular clusters. Quite easy sometimes to overcall a cluster like this within a reactive background. This is an ascitic fluid, and with a history of cirrhosis, it's very, very likely that the cells will be reactive. And at high power, we can actually see these clusters, not too many nuclei. They've all got a reasonable space between them. You can see the cell junctions quite often between these reactive mesothelial cells, and the nuclear chromatin is fairly even across all the cells. They look kind of the same with a small nucleolus. Mesothelial cells can acquire vacuoles either as a reactive or degenerative reaction, and these can be confused with signet ring carcinoma. It's important, therefore, to pay attention to the nuclei. Here we can see there are small nuclei in binucleate mesothelial cells. Vacuolated macrophages can also pose a problem in reactive effusions. Quite often there's more than one vacuole and frequently 2, resembling 2 little butt cheeks there. It is fair to say that both with vacuolated mesothelial cells and macrophages, most of us have probably resorted to immunocytochemistry at one point just for our reassurance. The international system describes all these changes in reactive mesothelial cells under its negative for malignancy chapter. Moving on to malignant mesothelial cells. Now, these can be a challenge in cytology, especially how far to go in terms of a diagnosis. And I wouldn't say it's so much of a pitfall, but more of a murky mire. In the UK especially, we often end up calling abnormal mesothelial cells atypical mesothelial proliferation. The international system has a whole chapter on malignant mesothelial cells, and it recognises that there is a morphological overlap both with reactive mesothelial proliferations and also with metastatic carcinomas. But the system does actually stress that a diagnosis of mesothelioma can be possible in the situation where you have either the cytological criteria for definite malignancy, or you have the ancillary studies which are characteristic of malignant mesothelial cells, such as loss of BAP1 and homozygous deletion of P16. In reality, a final diagnosis of either malignant mesothelioma, suspicious for malignancy, or atypical cells of undetermined significance will depend on correlation with the clinical and the radiological context. Here we have a case of a man who was 73 years old with a right-sided pleural effusion, ? Cause. We received 40 ml of cloudy yellow fluid. You can see the sample, it is supercellular, very, very cellular, three-dimensional clusters, blackberry-like, or what we call in Scotland, bramble-like papillary clusters. And this is what brambles look like. I'm afraid this supercellular cluster would have been more so had I not eaten 2 of the brambles prior to taking a photograph. On the PAP, again, you see these blackberry or bramble-like clusters in an overall supercellular background with single abnormal-looking mesothelial cells in the background. Some of them are vacuolated, some are clasping. The cell block preparation shows abnormal cell clusters, which on immunocytochemistry express very strong membrane and cytoplasmic staining with EMA and show loss of BAP1. We have morphology, which shows abnormal cells, which look mesothelial, confirmed by immunocytochemistry. And on this alone, I think we could be at least suspicious for malignancy. In addition, however, strong EMA membrane staining, Desmin negative, and crucially, loss of BAP1, together with CT scan showing pleural thickening, would be sufficient to make a final diagnosis of mesothelioma in this case. I would still recommend VATS biopsy if it's possible. VATS biopsy in this case confirmed mesothelioma, but interestingly with a sarcomatoid component, which cytology would be unable to predict. Here's another case, a lady of 71. She was an ex-smoker, presented with breathlessness. She had a large pleural effusion, but no history of asbestos exposure and ? Cause. We received 47 ml of very viscous, deep yellow fluid. And again, it's got clusters of cells. It's quite supercellular, although less in the way of single cells in the background, but lots of these three-dimensional clusters. At higher power, the cells have really nasty, malignant-looking nuclei with prominent nucleoli and a high nuclear to cytoplasmic ratio, but it's impossible really to be sure if these are mesothelial or epithelial. However, a cell block on which you could do immunocytochemistry showed strong positivity with the EMA and also with other mesothelial markers. So the initial impression is they look malignant, but interesting in this case, there was no loss of BAP1, multiple biopsies were inconclusive, the clinical picture was unclear, and at a later date, P16 FISH was done and it showed a heterozygous but not homozygous deletion. So it's difficult to know how far to go with this one. I think at least we could have gone suspicious for malignancy, probably based on the horrible morphology. Malignant would also have been appropriate, and indeed 2 years later invasive mesothelioma was confirmed. Making a new diagnosis of malignancy in serous fluids almost always requires immunocytochemistry. Determining whether it's mesothelioma or carcinoma, you should really include at least 2 markers of each in your panel. With respect to site-specific markers, you'll have your own departmental favourites, but you can also include other stains like PAS diastase. Sometimes immunocytochemistry is required for subtyping of tumours, including, say, for example, ovarian tumours, and increasingly immunocytochemistry is required for therapeutic and prognostic information, especially in lung and breast. When choosing your immunopanel, it is important, therefore, to be sure of a clinical setting and to do an ICC panel appropriate to that. However, there are always caveats with diagnostic immunocytochemical markers, especially in cytology, where there are cell mixes and a lack of architecture to place the ICC. Some examples in serous fluid include the fact that WT1 stains both mesothelial and serous adenocarcinoma, which we know, but also can be positive in basal phenotype breast carcinoma and squamous cell carcinoma. GATA3, which we use commonly for breast carcinoma, is also positive in up to 50% of mesotheliomas. And some of the mesothelial markers, CK56, D240, calretinin, can also be positive in squamous cell carcinoma. Mesothelin is positive in ovarian and pancreatic carcinoma as well as mesothelial cells. And importantly, with mesothelioma, some of the usual mesothelial markers may be lost in malignancy, and therefore it makes sense to have a panel when undertaking immunocytochemistry. Moving on, not just mesothelial cells, but also in the situation of metastatic carcinoma quite often, there are cytomorphological issues that can make the diagnosis tricky and set us up for pitfalls. Cell balls can be really useful and characteristic features in malignancy, but they're also not specific. Single cells, are they epithelial or are they mesothelial? Problems when you've only got a few abnormal cells, or when the morphology is bland. Definitely in making a diagnosis, correct diagnosis of metastatic malignancy, we need morphology and immunocytochemistry to work together. Next case is a pleural fluid in a lady of 71 with a history of previous breast cancer and also a liposarcoma, and the fusion was malignant. You can see on the cytology it's very cellular and it's composed of these extremely tight balls of cells standing out against the background. At higher power, we can appreciate that these balls have a community border and a rather cannonball-like appearance. Some of the nuclei are pushed to the edge. There are visible nucleoli and not many single cells in the background, so the balls stand out as foreign against that. Here we can see these glandular clusters on the cell block, and they stain positively with GATA3, confirming metastatic carcinoma of the breast. And these very typical cannonball clusters can be almost diagnostic of breast carcinoma. Here's another case. This time there are a few clusters, but also many single cells in the background. At higher power, some of the clusters seem to lack a community border, and the single cells have a frilly border, some reddish cytoplasm, eccentrically placed nuclei. From assessment of the nuclei, we can see how irregular they are, and the cells are obviously malignant. The question is, are they epithelial or mesothelial? In this case, we were given a history of previous breast cancer, and the cells on immunocytochemistry were positive with ER and GATA3, confirming their breast origin. Another potential pitfall in metastatic breast carcinoma is when the cells don't present in cannonball clusters, but as singly dispersed cells. These can be easily overlooked as a population of just reactive mesothelial cells. However, the clue is in the nucleus. There's actually a high nuclear to cytoplasmic ratio, and the nuclei are abnormal with nucleoli and irregular coarse chromatin. Another pitfall in interpreting metastatic adenocarcinoma is when you've got very few abnormal cells. And here's another case, this time lots of inflammatory cells with macrophages and mesothelial cells in the background. But here and there are these cells here with a very large nucleus, high nuclear to cytoplasmic ratio, and irregular nuclear outlines. The international system does allow us to go through an algorithm to help to sort out how these cells might be reported. So say we've got a small number of atypical cells like this situation. Are they macrophages? Well, they don't look like that. Could they be mesothelial cells? Unlikely. Are they epithelial cells? Probably. So we probably at first could say these are atypical cells of undetermined significance, just as there's only a few of them. But then doing ICC may demonstrate that the cells in fact are epithelial and they're morphologically atypical. So we could put a final report out as suspicious, depending perhaps on the clinical history, or malignant if we had a supportive clinical history. Case, this lady had a history of previous breast cancer, and we were able to see that the cells scattered around were positive both with ER and GATA3, and at the end of the day, because of the history, could make a diagnosis of metastatic breast carcinoma. Here's another case. This time it's a left-sided pleural effusion in a smoker, a lady of 76. She also had a history of breast cancer previously and bladder cancer in the past as well. This time the fluid is less cellular and contains these scattered small clusters of cells. They have very angulated nuclei and actually quite large compared with the lymphocytes round about. In addition, the nuclear chromatin has a rather pinkish look. This is a case of small cell carcinoma. This time it's not metastatic breast carcinoma. We have the small clusters are rather clasping with chains and the stack of coin-like appearance. There, as I mentioned, on a Ginsa, the nuclei can have a sort of pinkish look. Small cells often a pitfall, partly because there can be only a few cells, and the nuclei are much larger sometimes than you would expect. The cells can also have a reasonable amount of cytoplasm and can form these glandular clusters, as well as having small nucleoli. On the subject of cells with minimal cytoplasm, lymphocytic effusions can be a problem. They're very common, of course, and the international system does stress that there's no need for routine immunocytochemistry if there's no clinical suspicion of malignancy and the cells look normal. If, however, there is an abnormal lymphoid population present, you may end up classifying it either as AUS, SFM, or malignant, just depending on how far you're able to take it on cytology. Here we have a typical lymphocytic effusion with small, regular, unremarkable lymphocytes. They'll mostly be T cells on immunocytochemistry in a reactive effusion. And it's interesting, this one, there's also numerous eosinophils, and it's interesting to see how difficult they are to spot on the ThinPrep PAP preparation. And here we have a case of a pericardial fluid from a male of 23 years old with a pericardial effusion. At the time, he was under investigation for a possible leukemia. And we can see, looking at the cytology, the first thing that strikes us are these large reactive mesothelial cells, and they really catch the eye. So you do have to remember that pericardial fluids in particular can contain very florid reactive mesothelial cells and can be a bit of a pitfall. However, close inspection of the background lymphoid population, we can see that they're morphologically atypical. They're larger, they've got coarse nuclear chromatin, and many have a nucleolus. We were able to check the clinical history, and we performed ICC, which showed positivity with TDT, CD3 and CD10, along with other T cell markers. Therefore, the morphology, together with the immunocytochemistry, allowed us to confirm involvement of the pericardial fluid with a recently diagnosed pre-T cell acute lymphoblastic leukemia. Here's another case, this time a pleural fluid in a patient with known mantle cell lymphoma. So we thought we knew what we were looking for, and indeed, looking at the slide here, we can see that the lymphocytes are smallish but do have slightly abnormal nuclei, and therefore that would prompt us to do the mantle cell lymphoma panel. However, on close inspection, we can also see that there are these clusters present. The cells have nuclei pushed to the edge, rather glandular looking cluster. The nuclei are large, they are variable, and there's a moderately abundant amount of cytoplasm. So we did a cell block, and we could see again these cells here with more abundant cytoplasm, vesicular nuclei and nucleolus. In the background are the lymphocytes, and these stain positively with cyclin D1 in keeping with the mantle cell lymphoma. However, we can also see that these clusters are staining up with CK7, and there are cells positive with TTF1. So it can sometimes be a pitfall when you find a second pathology more than the one that you were expecting. So in summary, we can report this case as malignant, consistent with the known mantle cell lymphoma, but also containing metastatic pulmonary adenocarcinoma. It is worth noting that this kind of sample with a large number of background lymphocytes and only a few epithelial tumour cells is not best suited for PD-L1 or EGFR mutation testing. At this point, I'd just like to highlight the potential pitfalls with lung biomarker immunocytochemistry. Remember that TTF1, depending on the clone used, can be very pale and subtle and can be extremely patchy, leading to a potential false negative. Lung ALK staining really must be strong to be positive, and remember not to call this background staining in macrophages, which is non-specific, as positive. Similarly, PDL1, it needs 100 cells in order to assess PDL1 status, and also it can be positive in macrophages and lymphocytes. Remember too that for lung and for any other site, these tests must be validated on cytology. Gynecological samples are common and important. With ascitic fluid, it's often the initial diagnostic material, and with peritoneal washings, a positive washing may impact on staging and/or treatment. We have to bear in mind that low-grade morphology has to be considered, however, in the context of the histological specimen, and that can sometimes be a pitfall. This is a washing taken during laparoscopic removal for a benign serous cystadenoma, but interestingly, histologically, it was described as having a defect where the fallopian tube was attached. The group itself looks a little bit worrying, quite hyperchromatic. However, at higher power, you can see that these cells are ciliated, and therefore, given the clinical scenario, we concluded that these were benign tubal cells and that the washings are negative and not AUS. This next case is from a female of 57 with a history of borderline serous tumour and ongoing peritoneal nodules. At low power, there are background mesothelial cells and inflammatory cells, but these very prominent papillary clusters. High power shows that these clusters contain cells showing really mild atypia, so they're not high grade looking. And on the cell block, we have obviously serous type epithelial cells surrounding a psammoma body. The international system recommends that we call these cells atypical cells of undetermined significance until they can become correlated with the histology, because borderline tumours are certainly staged according to the ovary, and the nature of these low-grade serous cells are really quite difficult to assess on cytology. And indeed, the biopsy showed ovarian serous borderline tumour with non-invasive implants, and we could conclude that the cytological appearances were in keeping with that. Here are washings from another case. It's highly cellular, as you can see, with numerous papillary fragments and balls. As there is actually some nuclear atypia, I was initially tempted to call this low-grade adenocarcinoma, but as low-grade serous lesions do need to be correlated with this histology, the international system would recommend calling this AUS, at least in the interim. And we can see that in correlation with histology, there were a bilateral ovarian serous tumours with micropapillary type with an exophytic surface component, and that probably explains why there was very florid cytology. The omentum contained non-invasive desmoplastic implant. As well as gynecological samples, gastrointestinal pathology can also present some pitfalls. According to the international system, if we see mucinous samples with very few cells showing mild atypia, we still need to consider it suspicious for malignancy, in particular diagnosis of pseudomyxoma peritonei, which may then be clinched on immunocytochemistry. This next case is a peritoneal fluid from a man of 73 presenting with disseminated peritoneal disease, and we received 3 mL of jelly-like fluid. Cytologically, there was a background of abundant mucinous material in which there were only a few scattered groups of atypical looking cells. And according to the international system, given this presentation cytologically, we should be suspicious of malignancy. The international system does provide an algorithm for sorting out these suspicious cases where we have a small number of cells on our sample. We're favouring malignancy. Preliminary reporting could be suspicious for malignancy until we have done some immunocytochemistry. That may confirm the cells as being malignant epithelial cells, and therefore we can make a diagnosis of malignancy. Alternatively, if there are insufficient cells on the cell block or the ICC is equivocal, we may have to stick at suspicious of malignancy. In this case, there was mucinous epithelium in our cell block in fragments, and these stained positively with CK20, so we were able to confirm the diagnosis of pseudomyxoma peritonei. Although quite infrequent, metastatic colonic adenocarcinoma can also be a problem in serous fluids, particularly as often the cellularity is quite low, and the cells themselves can be vacuolated but may well not show a particularly columnar appearance. You can see them there in the cell block, but on immunocytochemistry it can be very helpful if the cells stain positively for CK20. Finally, we mustn't forget the pitfall of non-cellular elements. In this case, the fluid shows fecal material following an intestinal perforation. In summary, avoiding the pitfalls in serous fluid cytology involves taking into account the clinical history. When making assessment of the fluid, we need to recognise the sample type, as well as paying attention closely to the morphology, both architecturally and cytologically, often alongside the immunocytochemistry. I think that applying the information in the international system, as with the Paris system, can be very helpful in reaching the correct and specific diagnosis. But we do need to be aware of the range of appearances of malignancies in serous fluids, and especially for trainees, there's no substitute for experience seeing as many cases as possible. Thank you.
Thank you, Louise, for another very informative presentation and some really great cases in there. I'm conscious of time, but there are a few questions that come in on the chat that I think would be really of interest to everyone. First one is, do you have any experience in using Claudin-4 in differentiating carcinoma versus mesothelioma effusion?
No is the answer. We don't have it in our lab, so I've never actually used it as part of a meso versus carcinoma panel. I do know that, and I put it on the slide there, that some centres have what we call the Brescia panel, and that's Claudin-4 and BAP1, which has, I think in the literature anyway, been quite successful in discriminating mesothelioma from adenocarcinoma, Claudin-4 being positive in adenocarcinoma, and BAP1 being lost in mesothelioma. But personally, no, we don't have it in our lab.
Okay.
There's quite a good question here. Finding one of the listeners finds it difficult to identify a second population to decide between mesothelioma and adenocarcinoma. And the bottom line is, as I've shown you in the cases, sometimes it's easy. Much more easy in a scitic fluid, but in pleural fluid, when you've also got the issue of mesothelial cells and mesothelioma, it just sometimes is difficult. If you get a nice straightforward one with the very tight clusters, say in metastatic breast carcinoma, and the background has got lots of macrophages, it's easy to compare the nuclei. Often in an adenocarcinoma, the nuclei will be big, so compared with the cells in the background, and probably more pleomorphic, and the way the vacuoles are often clearer vacuoles, so they're not the dense cytoplasm that you get in mesothelioma. So you can sometimes see these more delicate vacuoles, I suppose, in adenocarcinoma, but sometimes you just absolutely do have to resort to ICC to distinguish, and we're lucky we have that. I once on New Year's Eve reported something as metastatic adenocarcinoma. Now this is 20 odd years ago, and 6 months later the surgeon said, would you review the diagnosis because the patient is still alive? And in actual fact, they had a mesothelioma, whereas in those days, if they'd had metastatic adenocarcinoma, they would have died. So we've all fallen in the pitfall. It just sometimes is tricky.
It is there. I see someone's just asked for abbreviations, just to let everyone know that these presentations will be are recorded and will be up on, but I don't know, Louise, if you want just...
Yeah. SFM is suspicious for malignancy, and MAL-P was malignant primary. In the international system, the malignant is divided into MAL-P, which is actually reserved for mesothelioma, and MAL-S for secondary malignancy. So and it was on the slide again, so we'll be able to see that in the preparation later, but yeah.
That's great, thank you. Again, I'm sorry about the timing here. Again, very interesting cases, and I'm sure we could talk on a little bit longer, but I am conscious of the program time. We would be due to have a break and start the next presentation, but I think we'll still go for a short break. I think we probably need that. So if we could come back at, just allow 5 minutes, so just after 10:45, and then I'll be able to introduce Dr. Munonyara. Thank you.
Hello.
Hello, Martina, we're going to just take a very short break. Is that okay?
Yes, that's fine.
Thank you. Hello, everyone. Welcome back. Hope you've had enough time for a short comfort break there. I'd just like to acknowledge some of the comments back in the chat there on Louise's presentation. So getting some really good positive feedback there. So thank you again, Louise. So our next speaker is Dr. Martina Munonyara. Sorry, Martina. And she's going to present on head and neck cytopathology, including thyroid and salivary glands. And Dr. Munonyara is a consultant cytopathologist in Guy's and St. Thomas's Hospital. I don't know if you can share screen, Martina, for your presentation.
Not at the moment.
Yeah,
yes.
Brilliant.
Okay. Can you see that?
We can.
Excellent. So I'm just going to stop my video so that you can see the presentation a bit more. Let me just play from the beginning.
Perfect, thank you.
And okay, so good morning, everybody. My name is Martina. Thank you very much for joining today. Unfortunately, we couldn't have met in person, but I think it's brilliant that there's such an international presence. I saw one of the delegates was from the Philippines, so absolutely amazing to see the enthusiasm for cytopathology this morning. So today I'm going to talk about pitfalls regarding head and neck cytology. So I'm sure you'll all agree, but that there are numerous pitfalls when we talk about head and neck cytology. And what I'm going to do in the next 30 minutes is just to focus on 6 pitfalls which have been encountered in regular practice and illustrate these with interesting cases. Hopefully they'll be very educational. Some of them are common and they are challenging. So what I will do is look at the various cytopathology associated with the pitfalls and potential ways to deal with them. So starting with the salivary glands, what makes this really difficult is these are a heterogeneous group of tumours. As you can see, this is taken from the WHO Blue Book, the 5th edition, and there are more than 30 different types of salivary gland tumours with variable morphology, phenotype and genotype. So this makes it extremely challenging for us as cytopathologists, but probably what is reassuring is that over about 50% of them in our everyday practice will be pleomorphic adenoma and Warthin's tumour. So just to discuss again why we see these challenges and pitfalls within salivary gland. So as I specified that they are a heterogeneous group of tumours, but despite this, there are numerous tumour characteristics which overlap, which makes interpretation by morphology rather challenging and even by immunohistochemistry. We're really good on the FNA to distinguish high-grade and low-grade malignancy, but unfortunately, one of the difficulties is trying to distinguish benign from low-grade neoplasms. Because of this, there is a high risk of false negatives with salivary gland neoplasms. High-grade tumours we are able to identify, but it may be difficult to subtype the different types of high-grade tumours. One of the limitations of cytology is that there are benign and malignant counterparts which would require the final histology. So this is another reason why this would be quite challenging on the cytopathology. Probably one of the most notoriously difficult areas is the batazoid cell neoplasm. And again, because there's such a range from the benign to the malignant, this is also going to be a huge challenge. And it's not infrequent that we do see metaplasia in salivary glands, and they love to mimic pathologies. So this is just an example in general how heterogeneous a group of tumours are, and yet there are different diagnoses. So I'm just going to refer here to the Milan system. So this has really helped to categorize salivary gland lesions, and they can be useful for the many pitfalls. I think here in Guy's and St. Thomas's, we've adapted to the Milan system, and it's kind of helped the clinicians to get more of an understanding what the morphology means. And in particularly with the SUMP category, the salivary gland of unknown malignant potential, it hasn't been something which is created, it's always been there, but it just gives a more uniform way of presenting a particular case. And as a result, I think it has helped to increase the credibility of using cytology, particularly because it's got an evidence base back into it, and it helps to relate to the management. And since then, there has been multiple publications, and there's a second edition which is yet to come, which has helped to refine the risk of malignancy. So first case, if we look at this as a left parotid mass, query neoplasm and query metastatic carcinoma. So this is in a 55-year-old female. We also know she's a smoker, and you can see here we've got a polymorphous population of lymphocytes. Not particularly any epithelioid cells we can see here. When we look on the PAT, we can see that there are these squamous cells, which some look like they are hyperchromatic nuclei, a little bit possibly irregular, but in the background of lots of lymphocytes and macrophages. And on further inspection, when we look, some of these look more like tadpole cells, there's some further ones here, but also there's some orangiophilia. So in the end, this was called suspicious for malignancy. This was discussed in the MDM, and the patient went on to have a left superficial parotidectomy. When we look at the histology, we can see there's a biphasic tumor here, in which you can see that it's got the oncocytic component, but there is some squamous metaplasia. So the final diagnosis with this was a Walden's tumor with squamous metaplasia. So there wasn't an overinterpretation with this. This is a very difficult case because of the squamous metaplasia. And the problem with this was that the sample was not truly representative because there was not any sampling of oncocytes. But being aware that cystic lesions are difficult, they may not be representative, and being aware that metaplasias, particularly squamous, mucinous, and sebaceous, can occur in Walden's tumor. The next case we have here is a 43-year-old male with a left parotid swelling, and you can see that there is porcelacellar aspirate in a background of lots of extracellular mucin. So you can see here there are some cells, difficult to really be definitive. Is this a macrophage? Is this going to be a mucocyte? And similar here, there's some squamoid appearing cells. So because of this, this was called atypia of uncertain significance due to the amount of mucin and the porcelacellarity of the specimen, because the importance here is that we cannot exclude a low-grade mucoepidermoid carcinoma, and this still could be a mucinous cyst. And this is where clinical and imaging correlation is always required in the setting of all of these lesions. The final diagnosis was a mucoepidermoid, a low-grade mucoepidermoid carcinoma. So if we just remind ourselves of the histology and correlating with the cytology, here you can see that you've got the squamoid cells, the intermediate cells, as well as the mucocytes or goblet cells. And when they are together as a sheet, it's so much easier to interpret in terms of the cytomorphology, and possibly there's some mucin here. Similarly here, you've got some nice dense squamoid appearing cells, and the more clustered ones together are the intermediate cells. And you can see why goblet cells, mucocytes are really difficult on cytology. They are eccentrically placed. They have a low nuclear to cytoplasmic ratio, and they can be easily misinterpreted as histiocytes. Histiocytes tend to be more singly dispersed, whereas mucocytes, if you do have a nice set of mucocytes together, such as here, they tend to be a bit more cohesive as they're epithelioid. So number one pitfall here was that the cystic salivary gland neoplasm. So because of variable sampling, these will have a range of malignancy. And how we can try and overcome that is that if you do have a solid component, is to try and also yield some material to try and increase the diagnostic yield. Similarly, rapid on-site assessment is very helpful to help in yielding more samples, but to see if there's more quantity, and also for the need of ancillary testing. And here, atypia of uncertain significance is important because the FNA here lacked qualitative or quantitative more details. It's really difficult to be confident whether it's a non-neoplastic lesion or a neoplastic lesion. So therefore, this is where MDM discussion is mandatory with correlation, because in this category, it's whether to repeat the FNA or whether there's enough information with the clinical findings to result to surgery. And probably one of the most important things to do is really to correlate with the histology to see where you can learn from these potential pitfalls. Just to also mention with the AUS category, this is really to avoid the false negatives, and low-grade mucoepidermoid carcinoma is one of the most common. And this is to really reduce that pitfall of underdiagnosing a low-grade mucoepidermoid. So I spoke a little bit about rapid on-site assessment of the head and neck specimen. And here we like to do ultrasound guided FNAs in which we can have a look at the direct smear. We usually have an alcohol fixed preparation that we will look at once it has been prepared. But we can do a rapid on-site assessment with a Giemsa prep. And in the case of certain morphologies, we can then decide if it's inflammatory, we can send some to microbiology. If there's a lymphocyte infiltrate, we can then send some for flow cytometry. Or if there's a difficult diagnosis where immunohistochemistry or molecular is going to help us to render a diagnosis, we normally do a cell block, but depending on how your laboratory is able to if it's validated for molecular testing, will determine which kind of sample you'll use. The next pitfall, and very common pitfall, is the cellular basaloid neoplasm. So in the Milan system, this has a subcategorization or in the SUMP category, because there is no definitive diagnosis can be made sometimes. So these, as you know, are a spectrum of neoplasms which can be benign or malignant. They are basaloid cells with high nuclear to cytoplasmic ratio and scant cytoplasm. And they tend to have scant thick matrix that produced by the myepithelial cells. These have a huge range of malignancy, but with the Milan classification, this is about 35%. And depending on the amount of material and clinical information, you may range a diagnosis from SUMP to suspicious to malignancy, because there may be enough to push it more to suspicious. And remember, not just the primary salivary gland neoplasms, there are also non-salivary origins. And this is due to the rich lymphatic drainage from the scalp. You do get cutaneous tumors. And this is where clinical information is going to be important in this situation. So this is just an example here. You've got a highly cellular smear here. But you do have some scant fibrillary looking stroma. And just to remember, this may not be representative of this whole sample. Here I've got a pleomorphic adenoma, kind of the prototypic that we always think about with fibrillary magenta matrix. Some people are likening it to troll hair and with very few epithelial cells. And on final histology, this turned out to be an adenoid cystic carcinoma. But this is the importance of trying to put it under the SUMP category, is because there is going to be difficulty into whether this could be a benign or malignant category. And these confer different managements. This is what we would normally like to see, is that you have these nice globular stromal fragments surrounded by basaloid cells. And you can see that this is mimicked in the histology, which is on the left, just to show you. And in view of the cellularity and as well as clinical features to help you, patient has pain, sometimes the location, particularly the small salivary gland, the palate, this indeed would be more in keeping with the adenoid cystic carcinoma. This here is a good example of a classic morphology that sometimes you can see with the membranous variant of the basal cell adenoma, where you have this acellular hyaline membranous material which wraps around the basaloid cells. And these tend to be supposedly more dense compared to the globules in an adenoid cystic carcinoma. However, this can still mimic other tumours, and as you know, that basal cell adenoma can only be definitive on histology because of whether there is infiltration of the capsule or if there is going to be lymphovascular invasion. Here is another example of a basal cell adenoma. Here that the basal cell, the basement membrane-like material is quite small and scant, and you can see that, but it would be difficult to differentiate this from a solid variant of an adenoid cystic carcinoma, hence why a broad category of the cellular basaloid neoplasm is preferred to prevent that pitfall. So this is just taken or adapted from the Milan system of reporting, where it's looked at the stromal characteristics. Because these have the myepithelial cells, which are secreting the matrix, and depending on the type of tumor, you'll get different characteristics. And despite there being different stromal characteristics, very difficult to be certain the type of tumor, because it's not going to help really distinguish unless you've got nice definitive features, such as here the globular features with the adenoid cystic. It is going to be difficult to differentiate something which is benign to malignant, but it is useful to have as part of your to be able to determine what the differential diagnosis is going to be. So next here, we've got a 33-year-old female, submandibular swelling, query salivary gland neoplasm. So firstly, you can see here, there's a lack of stroma, but you've got these nice basaloid cells, and they are kind of forming these well delineated shapes. Similar again on the PAP, you also do have this with scanty material basaloid appearing cells. And because of the scanty material, this was put under this category of SUMP. And because this was originally a rapid on-site assessment, more material was taken for molecular testing. So the material was sent for MYB, and this was shown to be rearranged. And you can see, I mean, here it says H&E slide. It wasn't a H&E slide, it was a Giemsa slide. And it did detect the presence of MYB, which would be consistent with an adenoid cystic carcinoma. So in this situation, to kind of try as much as possible to push the diagnosis to something more definitive, the use of ancillary testing here has been helpful. And this is the final histology, which showed that this was a adenoid cystic. And you can see it was actually quite confined to the salivary gland. This patient didn't have a history of pain, but you can see nicely here, this is the cribriform and glandular architecture of a adenoid cystic carcinoma. So here is just to remind you the types of molecular testing that you will or you can do on salivary gland neoplasms. This is adapted from the new WHO, and more of these are coming into fruition. But it just emphasizes again the use of rows to get more material, and depending on how your genetics lab is able to perform these tests, depending how they've been validated, these can be highly useful. And molecular testing throughout pathology is increasingly being used, but you'll still always need morphology to determine which test you are going to use. This is just to remind you about some of the pitfalls with these kind of these neoplasms. So this was a left parotid gland swelling, query salivary gland tumor. And here again, you've got basaloid appearing cells. Could this be a fibrillary type matrix? This is on closer inspection. You can see low nuclear to cytoplasmic ratio and more of this kind of scant stroma. So this was put under the cellular basaloid neoplasm diagnosis. Patient underwent further histology, and you can see this has the classical appearance of a ameloblastoma. The surgeons didn't tell us that there was a previous history of a ameloblastoma, but you can see how here this can easily look like a cellular neoplasm, basaloid neoplasm. Similarly, again, this is a lip lesion in a 64-year-old female. And this was originally diagnosed as a basal cell neoplasm. This was actually a basal cell carcinoma of the lip. So just to remind you that the cutaneous lesions, basal cell carcinoma, basaloid squamous cell carcinoma, and Merkel cell carcinoma, which can frequently occur on the head and neck, the face of the head and neck, these can be seen to metastasize to the salivary glands due to the high rich lymphatic drainage. So when we talk about the pitfall of the cellular basaloid neoplasm, this category works really well because we don't want to try to overcore or undercore, and really it's really engaging a discussion with the surgeons. As I said here, the surgeons are more understanding what this category is and thinking about using rapid on-site assessment for more material for ancillary testing. And really what you want to do as much as possible is whether you can push for a more definitive diagnosis and therefore to guide management. So the next topic we're going to look at is at the lateral neck. And probably one of the most challenges to the head and neck cytology is whether something is a branchial cleft cyst versus a cystic squamous cell carcinoma. And this is highly difficult because of the anatomical position of the branchial cleft cyst. As you know, it is a derivative of remnants from the second branchial apparatus and tends to be in the location of the anterior 2/3 of the upper neck, overlying the sternocleidomastoid muscle. And also with the case of the cystic squamous cell metastases, because of metastases commonly to the level 2 or wherever in the neck, but a jugular digastric node being in a similar area, this can be difficult to differentiate both in terms of clinically as well as on the cytology. The other issue we have is that with branchial cleft cysts, yes, there's a bimodal presentation of less than 5 years, but the older population of the 20 to 40 is also overlapping when cystic squamous cell carcinomas tend to be more common getting towards the 40 years old category. These are prone to repeated infections, and this can be highly challenging. And in this paper, it is thought that malignancy in patients could be up to 56% in those who are greater than 40 years old versus those less than 40 years old of about 1.6%. So this is very typical features when we have a nice case that you have these superficial or intermediate squamous cells lacking cytological atypia, some of them anucleated with this keratinous debris. You may have the case of cholesterol crystals, that this is a long-standing lesion, and some mild atypia. And these are non-specific findings, squamous cells of various maturity, background of some lymphocytes and macrophages. If you think, what a branchial cyst, it's a lymphoepithelial cyst in which you may get the lymphoid component seen on the cytology. This was a 54-year-old male with a fluctuant neck swelling, query-infected branchial cyst. But you can see this is an obvious squamous cell carcinoma, clinically presenting as a branchial cleft cyst. But when the cytomorphology is evident, this is obvious that it's going to be a squamous cell carcinoma, which this was. This was another 55-year-old male, query branchial cleft cyst, and here you can see some which are anucleated, others which are looking like superficial squamous cells. And again, they tend to have non-specific features here with some debris, but on the final histology, this turned out to be a well-differentiated squamous cell carcinoma. This was just an interesting paper where it just kind of showed that it is extremely challenging and difficult, where there were two cytopathologists which were trying to distinguish between features of a branchial cyst versus a metastatic squamous cell carcinoma with a complex multivariate analysis of 19 different features. And still there was no features which were significantly significant. The closest ones was the high NC ratio, regular nuclear membranes and small cell clusters, which is obviously what we would normally look for when we are looking towards a diagnosis of a squamous cell carcinoma. And this is extremely challenging, but the importance of correlation is important. The age of the patient, is the patient a smoker? Features on imaging are still key. Here in the paper, they alluded to ancillary testing, the use of P16, aneuploidy and HPV-ish in the cases of the HPV-associated squamous cell carcinomas. As you know, that they can present as a carcinoma of unknown primary in the neck. These may be helpful. So, as I said before, these are highly challenging and require good clinico-pathological correlation. I must say the head and neck surgeons tend to be forthcoming with this diagnosis and tend to perform panendoscopy because they are aware that in the older category, the over 40 years old patients, these are more likely to have a squamous or a cystic metastases, but obviously branchial cysts can occur. So it's really important to engage with this discussion. Ancillary testing with P16 and aneuploidy testing, as stated before, could be helpful in the case of those HPV associated, but this requires validation of the cytology samples. And there is a discrepancy on the type of cytology samples, and it really depends on the validation of your laboratory of what you use, whether you do use a liquid-based sample or whether you're using cell blocks, because there will be different thresholds for diagnoses. And just to remind you that you can have P16 positive squamous cells which occur in branchial cleft cysts. So this requires correlation with the clinical of what this could be. So in isolation alone, you would not use this to be definitive, but it may be a helpful adjunct. So this is another case. This is looking at a cervical lymph node now in a 45-year-old patient with lymphadenopathy. And the question here was whether it was granulomatous inflammation. And as you can see, there is a diffuse lymphoid background, but you can also see that these larger discohesive and clusters of cells, that when you look in more higher power, you can see some of them appear a bit more cohesive, but there is an element of pleomorphism. So this was seen as a poorly differentiated malignancy because it was very difficult to see whether this was going to be a lymphoma or whether this is going to represent a carcinoma. So because this was a rapid on-site assessment, a core biopsy could be obtained, and similar to the cytology, you can see there are cohesive clusters and singly dispersed cells in a background of lymphocytes and plasma cells. And further immunohistochemistry showed that these larger cells, epithelioid cells, were P16 positive, P63 positive, and EBA positive. And this revealed that this was a nasopharyngeal carcinoma, a non-keratinizing, undifferentiated. So you can see there is a range of possible diagnosis associated with this. This is classical Hodgkin's. You can see here that these prototypical cells, the Reid-Sternberg binucleated prominent nucleoli. Here you can see a high-grade neuroendocrine Merkel cell carcinoma, which does occur commonly in the head and neck, but the use of the CK20 to look for the like positivity, as well as the looking for the neuroendocrine markers and MIB is helpful. Do not forget a metastatic medullary carcinoma, medullary thyroid carcinoma. You can get giant cell types which can mimic the presence of, it can mimic other pleomorphic looking tumors, and metastatic small cell carcinoma can occur. So nasopharyngeal carcinoma does often present as an advanced disease, as the primary is often occult. So as a cytopathologist, you may be the first to make the diagnosis. And this is where rapid on-site assessment has been helpful, because a core biopsy to obtain as much tissue as possible in that differential. Could this be an underlying lymphoma, or is this going to be a poorly differentiated carcinoma? In terms of immunohistochemistry, CD13 EBA is not going to help distinguish between classical Hodgkin's lymphoma with a nasopharyngeal carcinoma, and the use of a panel is really going to be helpful here. So lastly, I'm just going to talk about thyroid gland. So this is a 45-year-old male with a 3 centimeter thyroid mass, and you can see here on imaging, this is a hyperechoic mass which was termed as U5. This is a corresponding aspirate, and you can see it's a highly cellular aspirate with these cohesive group of cells, which on closer inspection, you can see some of them, there is a degree of pleomorphism. Possibly there's some, is there necrosis in the background? Difficult to tell. And here there's possibly a hint of internuclear inclusions. And here on detailed inspection, some of these cells look a bit smaller, but then you've got more pleomorphic looking cells. So this was originally called a Thy5 because it malignance. And could this be a poorly differentiated thyroid carcinoma with a well differentiated component, whether this is a oncocytic variant of a PTC, or could this be a medullary? So the patient underwent a total thyroidectomy with the histology. You can see here that there was invasion into the thyroid gland of these epithelial cells, invasion into the strap muscle, so definitely dealing with a malignant lesion, vascular invasion, and tumor necrosis. But this was in fact a parathyroid carcinoma. So just looking at the differentials of an oncocytic neoplasm, you can see here they are all going to have granular abundant cytoplasm. In this case of an oncocytic neoplasm, a carcinoma, immunohistochemistry is going to be very helpful, but the subtle hints there were that there was some smaller regular cells with features of some pleomorphism. Sometimes you can get that in the parathyroid carcinomas. These are incredibly rare, but it's just something to consider. And really immunohistochemistry and the ancillary testing really here is going to help, particularly with biochemical testing of serum calcium, and PTH is going to help. GATA3 and PTH would be positive in these tumors, and the thyroglobulin and the TTF1 is going to be negative. So again, it's really important to have a panel to distinguish between all of these things. So consider this in your differential of an oncocytic neoplasm of the thyroid, highly tricky differential diagnoses. These are very difficult in histology. And MDM discussion is critical in helping you to reach the diagnosis. We did find out later this patient did have bone metastases. They did have a high PTH, but interestingly here they had that, this is an intrathyroidal parathyroid carcinoma. So looking at the last case, this of a 45-year-old with a right thyroid mass. And you can see this is cohesive group of epithelioid cells showing a considerable amount of pleomorphism. And when you look here, some of them appeared a bit more spindled in places. And you can see that there is irregular nuclear contours and a bit of hyperchromasia. So the difference for here, this was called a Thy5 malignant. Could this be a medullary thyroid carcinoma because of the spindling and the singly dispersed cells, or could this be a poorly differentiated carcinoma? Patient underwent his histopathology resection, which showed that this was a metastatic melanoma. So just looking here, various metastases within the thyroid. And the majority taken from this series and that we know about tend to be the renal cell carcinoma and lung tumours. Cutaneous tumours do feature there, and they're about 4%. And it's just really important to just never forget melanoma because of the various disguises it likes to undertake. So again, this is a differential diagnosis of the kind of poorly differentiated tumors you may see in the thyroid gland. And with medullary thyroid carcinoma, you can see binucleation, plasmacytoid arrangement morphology, which you saw here on the cytology. And this is very common with all of these tumors: medullary thyroid, polydifferentiated thyroid, anaplastic thyroid carcinoma, and melanoma. Binucleation, multinucleation is highly common. And these are epithelioid, melanoma, which with an epithelioid morphology, there's going to be this overlap. And this is why it's important when you see an atypical, or what I should say is a lesion that just looks too pleomorphic, is to think about melanoma and to also think of a metastasis. And this is where your ancillary testing is going to be crucial, and taking more samples for a cell block to be able to do further ancillary testing in immunohistochemistry. So this is a major pitfall, the metastases. It's very rare to see a melanoma as the first presentation, but it does happen. And metastases in general represent 1 to 3% of thyroid tumours. And melanomas and renal cell carcinomas are commonly incorrectly diagnosed due to morphological overlap with the RCC because of the overlap of oncocytic lesions. Clinical history is essential. They may have had previous history, but here this was a first presentation. And this is important because treatment management is determined by the primary, so that whether they would do a total thyroidectomy in other cases, the case of obviously if he had a lymphoma, total thyroidectomy would not be indicated. So in summary, the head and neck has a huge plethora of potential pitfalls. It is having an awareness of what they could be. And there are limitations to cytology because histology will be the definitive overall. But rapid on-site assessment is of useful assistance because you can obtain more samples for ancillary testing, and correlation is essential in all of these lesions to whether what the further management is going to be. And you could see the Milan system was useful into helping avoid the pitfalls, particularly the AUS and the sump categories. And really, histology correlation is going to be of great importance, as this is going to help you to learn in the future, will help you to learn and forever learn where the pitfalls are. So lastly, thank you for listening. And if you have any questions, I'm happy to answer them.
Martina, thank you for another very interesting presentation today. I have a couple of questions coming so far. One is, I think it was to the general audience, but maybe people could add in messages there if they wish. But maybe you can answer from your scenario. Is, do you have separate passes into the lesion for the needle washout?
So if there is a cytologist who is there, yes, because you've made a diagnosis that this looks, for example, if I say in the use of a salivary gland tumour, it looks basaloid appearing, yes, we can ask for an extra pass to ensure that there is more material.
That's grand. And maybe others could add in to talk if they have any different practice. The last question there then is, what are your thoughts on H&E cell block for head and neck cytology? The audience member there says we do it in small numbers, less than 10 a week. They don't have rows and it works really well.
So here, because we do a lot of rapid on-site assessment, we would a lot of the time use cell blocks. It depends on the practice of what your surgeons and also the head and neck histopathologist, here particularly on thyroid and head and neck, they are reliant on fine needle aspiration diagnoses. So here we would do cell blocks automatically. In that case of that 33-year-old female who had the adenoid cystic, they wouldn't have gone for a core biopsy. And that's why for us, it's kind of important to have that rapid on-site assessment, that we can get extra material for the ancillary testing. And this is brilliant because we can push into another diagnostic category that this is malignant. The surgeons really like this because it kind of makes things a bit more definitive. They know that they're going to have to do a more radical approach to surgery in the case here. So yes, we are large fans of cell blocks. Similarly with cytology, we rarely or we hardly do core biopsies. For example, with the Thy3F, here we are reliant on cytology. The only cases we would go for core biopsies would be those for not knowing if there is a different type of malignancy, i.e. could this be melanoma, could this be something else? And just so that we have more information for ancillary testing for immunohistochemistry, and obviously this confers more material should there be anything for BRAF testing. But I would say that's down to where you work, and whether core biopsies are going to be your mainstay here is very cytology heavy.
Okay, that's brilliant. Thank you very much. And I would like to thank both our speakers so far, Louise and Martina, on excellent presentations. Thank you very much. We're now going to move on to cervical cytopathology. So we have a presentation by Dr. Tanya Levine, and she's a consultant histopathologist, a cytopathologist, and director of the London Regional Cytology Training Centre in Northwick Park. So we'll see her presentation, and then Dr. Levine will then be in for a live Q&A session. Thank you.
Hello everybody, it's a pleasure to be able to talk to you today, and over the next half an hour to 40 minutes I'm hoping to give you an overview of the cytological features of glandular cells and abnormalities in cervical cytology. So the aim of my lecture is to give an overview, as I said, of the histology and cytology of high-grade CGIN. And of course, if you're outside of the UK, you might be used to other terminology such as adenocarcinoma in situ. Discuss the cytological differential diagnoses, and then right at the end I'm going to present a local audit of the follow-up of query glandular neoplasia of endocervical type and borderline changes in endocervical cells. So, high-grade CGIN, or adenocarcinoma in situ. The incidence of adenocarcinoma in situ has increased over the last few decades. The peak age is about 30 to 40 years of age, and we know that the average interval between diagnosis of AIS and early invasive adenocarcinoma is in excess of 5 years. Over half of the cases coexist with CIN, and the majority are related to high-risk HPV, in particular HPV 16 and 18. And with respect to those, about 38 to 50% of all high-grade CGIN or AIS cases are associated with HPV 18, and that rises to about 50% of invasive adenocarcinomas. But interestingly, when we look at HPV 18 positivity with CIN squamous cell carcinoma, only about 5% of those are associated with that. And of course, HPV vaccination has shown a dramatic reduction in the incidence of high-grade CGIN. So cytology of query glandular neoplasia of endocervical type. This is when the sample shows cytological features suggestive of cervical glandular neoplasia, high-grade CGIN, or indeed endocervical adenocarcinoma. Now, in order to appreciate abnormality, you have to appreciate what is normal. Now, this actually is an H&E of a normal endocervical crypt, or crypts in fact, because we've got one that's cross-cut here. And just pointers. First of all, we have a lovely extensive area of endocervical type epithelium. And I want you to see the first of all, they're not all right bang at the bottom sitting on the basement membrane. Some of them come up into sort of almost the middle 1/3 of the cells, and they have a lovely plume of clear cytoplasm above them, and if you could do a DPAS Alcium blue, you would see that this is full of mucin. And depending on how the section is cut, they either look columnar, as you can see here, or here, if they're transected, you have a more honeycomb appearance with a regular arrangement of endocervical cells, and here regular arrangement of the nuclei. So, given that a PAP is a modified H&E, when we look at the PAP, we can see in this instance we've got a lovely strip of normal endocervical cells, which look very similar to what we're seeing here on histology. And if you use an analogy of wine bottles in a wine rack, normal endocervical cells, more or less, look as if they're all of the same type of wine and they're regularly arranged in this wine rack, not unlike what we're seeing here to here. And of course, Sometimes, depending on how the cells are presented in the cytology sample, you can see they have a more honeycomb arrangement, which looks exactly as you can see down here. And imagine that you were looking at these wine bottles end on now. So that's normal. By comparison, have a look at this H&E. Here, this is something that's abnormal, and your eye is drawn, even at low power, you can see that we have areas such as this which stain much darker than the background endocervical crypts. And of course, we can see that there's an abrupt transition between what looks like to be normal to something that looks more interesting. On a higher power now, you can see why it looks darker. So down here we have our normal endocervical cells, and remember I said the nuclei are in the basal 1/3, and some of them can go a little higher, as you can see here, with a little plume or lovely columnar mucinous cytoplasm above. By comparison, in histology we often see this abrupt transition between normal and abnormal. And what's abnormal about here is now the nuclei look enlarged. You can see, for instance, this nucleus is about, I would say, 3 to 4 times the size of the normal ones adjacent. Also, there's a range, even on the H&E, you can appreciate, of chromatin variation in staining. So we've got some that look, I would say, fairly euchromatic, others which look much darker, and some which seem to have sort of vacuolated changes. And of course, we've got this pseudostratification where we've got nuclei fighting to get to the surface and a diminution of mucin. So when we look at abnormal, we can clearly see a difference to normal. So going back to our wine bottles in a wine rack analogy, if you could say that over here was more or less normal with wine bottles regularly arranged in the wine rack, when it comes to high-grade C-gin, we've now got a chaotic distribution of wine bottles of different sizes and shapes in and out of the wine racks. And that's essentially what we're seeing over here. So I'm going to show you some cytology now, and this is the corollary. So normal on our left, a nice flat monolayer. On the right, this is high-grade C-gin. And again, back to our wine bottles in a wine rack, the best way to imagine this is now we're trying to cram too many wine bottles into each of those wine rack openings. And when we look at the nuclei in this instance, some of them look a little elongate, some of them are more stubby, but in fact the chromatin has this granular pattern to it, and you've got this depth of focus into a gland opening. This is on a higher power, and here I really want you to appreciate the chromatin. It has this very grainy appearance. In some groups, the nuclei look paradoxically much smaller than you would expect them to be. In others, they look the same size, or indeed, and here I would say the nuclei look larger than normal endocervical cells. We've got this super crowded glandular group, and the best way of imagining this is it's almost like an Elizabethan ruffle. If you imagine Elizabeth I's neck here, and this is this lace ruffle, this super crowded group around it. And you can begin to see a little bit of feathering, a little bit of elongation at the edges of this group. That feathering is seen much better here, where you can see these lovely elongate abnormal nuclei, this grainy chromatin, and this irregular feathered edge. This is another example of high-grade C-gin, and there's a number of things to see here. First of all, the chromatin. This is abnormal chromatin. It's too coarse and granular. Now let's have a look at the arrangement of these cells. They're elongate. They look like they are chaotic columnar cells. But in addition, we seem to have some asana openings here, and then right at the top here it's slightly overexposed, but can you see we've got some sort of fronds of cytoplasm that are rather irregular, and this is where the sample has literally been pulled away from the basement membrane and leaving little tags of cytoplasm. This is where the endocervical cells say have been pulled away from the basement membrane, and we've got little tags of cytoplasm, a bit like pulling a hair from your scalp, where the cells would have been attached into the endocervical basement membrane. Now, This is a different sample. This is slightly different staining, and depending on the lab you work in, you might see a slight variation in pap stains. But actually what you can appreciate here is, again, the supercrowded nature of these glandular groups, a gland opening here. But I also really want you to appreciate this abnormal chromatin pattern. Okay, these are not vesicular euchromatic chromatin nuclei. You can see the coarse granular appearance to this abnormal chromatin. And again here, this is another example of high-grade CGIN. Here it's not so much the feathering, it's more the fact that we have a depth of focus, and you can see obvious gland opening here and here, but again appreciate the abnormal chromatin. In this, it actually is hypochromic, and you've actually got a thickened nuclear membrane going on. Now, back to an H&E, okay? This is a photomicrograph of high-grade CGIN on a higher power, okay? And to orientate you, we've got our abnormal endocervical crypts here and here. But I want you to appreciate here a mitotic figure. It's the same with high-grade CGIN in cytology. So to orientate you, this is an abnormal group. You can appreciate here the nuclear enlargement and elongation of the nuclei. All of the nuclei look hyperchromatic, but this photomicrograph has been taken to show this structure here. This is a mitotic figure. Whenever you see mitoses in endocervical cells, always look carefully at the cells that the mitosis is in and the cells surrounding. Occasionally you can see mitoses in reactive endocervical cells, but in my experience it's much more common to see it as in association with high-grade CGIN. Now back to our H&E. So we've got an area of high-grade CGIN here. We've got nuclear elongation and variation in chromatin. We've got mitotic figures, as you can see here. But I want you also to see this stuff, which is apoptotic debris that we very commonly see on H&E. You can also see it cytologically as well. So once again, we have our abnormal supercrowded endocervical groups, our abnormal chromatin, but this photomicrograph is taken to show you these little black specks here, which is apoptotic debris. Now, occasionally high-grade CGIN cytologically looks a little different. And in this instance, what catches my eye is the fact that we seem to have some sort of honeycombing going on, but it looks chaotic. First of all, we've got sharp cell borders, and if you were to do a mucin stain, I would wager that you could stain all of these with mucin. Okay, the beauty of a PAP is it allows us to see through cellular contents and extracellular material so that we can see through the mucin to the underlying nuclei. And when we look at these nuclei, first of all, I want you to see the arrangement. Are they a regular honeycomb arrangement? I'd say no. I think we've got sort of vague asana openings and orientation here and here and here. Now let's have a look at the chromatin. Well, if we take this, for sake of argument, as being kind of all right, although I would say that the chromatin is still a little coarse, when you look at this one here in the same field of view, you can field of focus rather, you can see that this is slightly darker staining. And then if we go right over to this nucleus, you can see that it's subtle, but it's there. The nuclear membrane is exaggerated, as you can see here. So I think we have abnormal chromatin pattern and arrangement, and this is intestinal type of high-grade CGIN, and was shown on histology to be that. And you can see the same case, a different area, and you can see that although we can see well punched out and discrete glandular cells with obvious mucin on a PAP, you can predict that this would be mucin within the cells. Their arrangement is not normal. If these were normal endocervical cells and a normal honeycomb, we would see the nuclei regularly distributed across the full area of this cellular group. And instead, we've got gland openings here and here and here. We have variation in size and subtle variation in changes in chromatin, looking a little hypochromic here, an exaggerated nuclear membrane here, and slightly coarser chromatin here and here. just want to touch upon SMILE, stratified mucinous intraepithelial lesion. Can be isolated, can be associated with high-grade CGIN and HSIL as well, or high-grade CIN. The cytomorphology of SMILE is not easily recognized. This is a paper from 2016 where they looked at 13 cases of histologically proven SMILE and did a retrospective review of the cytology provided. And that showed a very variable interpretation by the review panel, which I think is probably a nice way of saying that nobody could really agree. In SMILE, they did state that in these 13 cases, feathering and prominent nucleoli were absent. And high-risk HPV was detected in all, and it was typically high-risk HPV 18. So, the differential diagnoses of high-grade CGIN. You've got to think about reactive changes in endocervical cells, endometrial cells, and conditions where you find endometrial cells can always be problematical, either because it's a menstrual sample, or there's endometriosis, or tuberoendometrioid metaplasia, or indeed lower uterine segment. Tubal metaplasia can be a problem if you're not expecting it, as can reserved cell hyperplasia. And don't forget microbiopsies of high-grade squamous dyskaryosis, or in the Bethesda system, HSIL, can also be problematical. And of course, you can have invasive adenocarcinoma and extracervical pathology, extracervical adenocarcinomas. In truth, I think the last three can be sometimes difficult to differentiate from high-grade CGIN, but again, I don't think that's too much of a problem if you're predicting, let's say, severe dyskaryosis, and it turns and you think it might be into endocervical crypts, and it turns out to be high-grade CGIN. I think that's fine. So, reactive or inflammatory changes. Now, these are cases from a variety of audits, and the original diagnosis was ended up being query 6S, or query glandular neoplasia of endocervical origin. And I got a lot of sympathy with the reporting pathologists, because when you look at these groups, you can see that there seems to be some variation in where the nuclei are situated in the endocervical cells. But cast your mind back to the very beginning of this lecture when I started talking about normal endocervical histology, and I said the nuclei are not always at the base. Sometimes they can get to be in the middle 1/3. And in this instance up here, it's slightly higher, but I would say that probably these may not be so well orientated and slightly twisted. And then when we look at the nuclei, actually the chromatin is the same across all of them. The nuclear contours are smooth, and actually I look at this and I still see that within the realms of being normal endocervical cells. Again, this drew the eye because of the nucleoli. Now, endocervical cells are busy cells. They're busy making mucin, so the nucleoli are always can at times be quite prominent, and that's what you're seeing here. But interestingly, although the nucleoli are prominent, actually their arrangement of the cells look pretty uniform. The chromatin looks fine across all of them as well. These last two slides and this one are all from the same case. So you're beginning to see a spectrum of change here. And again, this was an area that was marked, and I can see why, because there's a variation in nuclear size. And there's some little prominent nucleoli. But first of all, they are more or less a flat monolayer. We haven't got that super crowded groups. We don't have pseudostratification. And I don't think we have significant alteration in chromatin. Nuclear size. Endocervical cells from time to time can show some variation within a sheet of size, as you can see here. This one is about 3 times the size of this one or this one. But look at the chromatin. It's the same across all of them. And I think we have an explanation for why we've got some of the cells looking a little teckled up, because we've got neutrophils insinuating themselves within the endocervical sheet. And if this was an endocervical biopsy, I'd say, look, there was a little bit of inflammation there, a little bit of endocervicitis. This was a different case, and again you can see why somebody might have been concerned by these endocervical groups, because they do have a somewhat three-dimensional quality to them. But when you look at them, first of all, the nuclei are all nicely orientated, okay? And they're orientated towards the basal 1/3 of the cell. And I talked earlier about these little tags of cytoplasm. Here we are, a little tag of cytoplasm where the cell has literally been pulled away from the basement membrane. And you can see that the chromatin across all of them is the same. The nuclear membranes are nice and smooth and round. We've got a little bit of information here. I wouldn't be worried by this. Now, I will talk about some of the features here in a coming slide, but again, this is not high-grade CGIN. You shouldn't be worried by this as being query endocervical dyskaryosis. What we're looking at here, we've got a range of appearances. These are all columnar cells, okay? The nuclei in these instances are, I would say, in the middle, sort of 1/3 to middle lower 1/3 to the middle 1/3 of the columnar cells. This you can orientate. You can just make out that there might have been, this is the top, and here we've got this little tag of cytoplasm here and here and here, where it's been pulled away from the basement membrane. But look, we've got lovely terminal bars and cilia. So this is tubal change. It's something you quite commonly see, particularly as you go up the endocervical canal. I wouldn't consider putting this in my report. The other thing to see is that some of these are multinucleated, and I'll talk about this presently. You've got a little bit of reserve cell hyperplasia going on here and here. So nothing to be worried about. Now, endometrial issues. I think endometrial cells, both in training and when you're out the other side of training as a reporting pathologist, can be very difficult at times. Menstrual changes. And again, when you're told these are endometrial stromal cells, yes, you say, yes, of course they are. But if you're not thinking about it, you can look at this group of cells and think, gosh, they look very hyperchromatic. I can see some possible distortion at the surface. Could this be feathering? And you can see some apoptotic debris here. But what I think we're looking at here are endometrial stromal cells which have lost their surface epithelium. Okay, so they look dark and hyperchromatic because these are coalescing in on themselves and going through apoptosis. And then when we go to the edge, you can see some of them have a more kidney bean shape, and you can just, with the eye of faith, imagining that nestled over that, you have these sort of curvilinear surface change to these nuclei. So these are endometrial stromal cells. On a higher power, again, just to show you, some of them have a more obvious kidney bean shape here and here and here. And although some of them are a little bit more cytoplasm, you've got the intermingled apoptotic debris. And these are endometrial stromal cells. This was, again, from the same sample. And here we don't have the stroma. What we have are the surface epithelial cells that are stripped away. And can look quite alarming, but when you see it in the context of the rest of the sample, these are endometrial. Lower uterine segment, okay? At low power, you're seeing very structural organoid, almost microbiopsies, as you can see here. On a higher power, lower uterine segment, these are supercrowded glandular groups, and you can see that these are small crowded cells, very uniform with one another, but they have a very sharp punched out architectural look and usually a very sharp anatomical border to them. You may also see some stromal cells. In this instance, we've got a lovely crisp anatomical edge, almost looks like a boot. And once again here, another example of lower uterine segment. No significant pleomorphism, no feathering at the edges. In this instance, I'm not really seeing the stromal cells, but often you can see them associated with. Now, tuberoendometrioid metaplasia. If you could do a Venn diagram between endometrial cells, lower uterine segment, tuberoendometrioid metaplasia, endometriosis, the intersection in the middle would be large with a significant overlap between them all. This is commonly seen post-conization, and there can be overlap with features of high-grade CGIN. Okay, the clues are the past medical history, previous conization. It can be helpful, and then again, it may not, knowing that. The textbooks will say smaller nuclei with grainy chromatin, don't tend to see single dyskaryotic cells in the background, no feathering. You may see endometrial stromal cells present. You may, in fact, see cilia and terminal bars, the tubo bit of it. In my experience, actually, it's a very tricky diagnosis to make with confidence, and sometimes you're ending up calling these samples borderline. This is an example, and this was called borderline changes in endocervical cells, and I can see absolutely why. Okay, you could even, if there were other groups looking similar, push it even higher to could this be query endocervical dyskaryosis. So what is it that's bothering me here? Well, I can see some the attempt of feathering and depth of focus, some nuclear elongation, although it's subtle, and the chromatin actually doesn't look too bad. So because I don't think I've got a full house of features, I probably would be marking that thinking, gosh, let me try and find something worse or something better. And if I was just left with this on my own, I think I would want to be on the safe side and call it borderline. The patient was discussed at MGT and ultimately went on to have a cone, and this is at low power. So you can see we've got we are in transformation zone. We've got an endocervical crypt here with surface squamous epithelium, but you can see on these two pieces my eye is drawn over to this. It looks much darker, and usually when endocervical groups look darker, it's because there's an increased NC ratio and something's going on there. And on a higher power, this was our tuber endometrioid metaplasia. You can just about see some cilia here. And that correlated nicely with what we had seen on the cytology specimen preceding it. Now, reserve cell hyperplasia. This is an H&E, and we've got the earliest reserve cell hyperplasia here with multinucleate endocervical cell. And again, this is more extensive going on here in the transformation zone. And this is the sort of thing you can see, multinucleate endocervical cells. But unlike CGIM, we don't see feathering. They look almost like bunches of grapes within multinucleate cells. The nuclei are very uniform and featureless with one another. Sometimes the cytoplasm can be lost and they just look like sort of hyperchromatic groups, but they're very uniform, difficult to tell apart in that instance from endometrial cells. I don't think it matters too much. The important thing is to recognize that the chromatin is featureless and this is not high-grade CGIM. Now, I'm going to touch on microbiopsies of severe dyskaryosis or high-grade SIL if you're using the Bethesda. These are notoriously difficult to photograph for lectures because you're looking at something with a great depth of focus and can be difficult to illustrate. So this particular field I took because I thought it would probably show the chromatin and the nuclear changes the best. But you can see how you could say, isn't that a gland opening here? We happen to also have a lot of inflammation in the background. When we look at these cells, in this instance, I think there's clear abnormal chromatin. We've got irregular nuclear contours, and a distinguishing feature from high-grade CGIM is that the quality of the cytoplasm looks cyanophilic. It looks as if it's squamoid. Also, you tend to have nice smooth edges. You don't have the feathering. Now, I'm going to touch on bland cell severe dyskaryosis. This is a tricky diagnosis and it can overlap because with endocervical issues, because at low power, bland cell severe dyskaryosis can be mistaken for either normal endocervical groups or indeed immature squamous metaplastic cells. Now, this whole sheet is bland cell severe dyskaryosis. And at low power, I think you could definitely swing over this and think, well, it looks a little, there is honeycomb here, there's the odd neutrophil, so maybe this is just a bit reactive endocervical. But what I want you to do is actually look at this sort of area here. First of all, we've got crowding here, but it's this sort of nucleus here with this irregular contour and this exaggerated nuclear membrane and this hypochromic change. This is the same case, a different area. And again, you start to see if these were normal endocervical cells, I would expect a normal, regular arrangement of nuclei. We're not seeing that here. Instead, we're seeing crowding and we're seeing subtle changes to the chromatin, subtle hypochromasia with thickening of the nuclear membrane. And this turned out to be SYN3 on subsequent cone. A word about extracervical adenocarcinoma. we do see it, and if we do see it now in our primary HPV testing, it's usually a sort of, it's not the reason why the sample has come through. The patient has high-risk HPV, and we also happen to have coexistent tumour from somewhere else. In this instance, this was a case of endometrial adenocarcinoma. We've got these balled up clusters of cells with a nice clean background. On its own, what would I be thinking about? Well, it could be also still be a case of invasive cervical adenocarcinoma, but you've got to think, when it doesn't look like your usual high-grade CGIN, you've got to think, could this be extracervical? Now, I'm just going to touch on HPV negative cervical adenocarcinoma. Papers will say that up to 15 to 38% of cervical adenocarcinomas are high-risk HPV negative, which seems very high, but don't forget this is cervical adenocarcinoma. In the cervical screening program, we are looking for pre-invasive changes. We are not looking to pick up invasive adenocarcinomas. They are rare, and they're usually more advanced and have a worse prognosis than HPV positive tumours. When we turn to high-grade CGIN, the high-risk HPV positivity rate does vary according to the histological subtype. Now, these are the much more common histological subtypes. They're much more common than our high-risk HPV negative, and these are the ones that we will pick up on screening. And I must again say that these are much, much rarer. Even in those high-risk HPV positive high-grade CGIN groups, sometimes you get false negative high-risk HPV testing, and there are a number of reasons for this. First of all, you can actually have an invasive tumour and it's necrotic, and you can have sampling errors with that, potentially blood and lubricant contamination. I am not a virologist, but a number of papers will talk about molecular features. HPV load and subtypes in adenocarcinoma can be low. The glandular epithelium may not be susceptible to persistent HPV infection, and copy numbers can also be low. And of course, I've already touched upon the rare subtypes associated with HPV-independent molecular pathways. So how do you know if you're correct with your diagnosis or predicting high-grade CGIN? Well, there's feedback when reporting if you're screening it or you're showing it to another colleague. Do they agree with you? Obviously, review for MDT. Does your peer group agree with your diagnosis? Audit, and of course, your national statistics as well. I'm going to present very briefly a local audit that I carried out of query glandular neoplasia of endocervical type and borderline changes in glandular cases at Cervical Screening London for between the 1st of December 2019 to just before first lockdown. This is unpublished, but I thought the findings were interesting. So we got out, identified all the cases, got them out. I reviewed them and then reviewed them with the outcome in histology and colposcopy where the information was known, and I looked for any possible diagnostic pitfalls in morphological interpretation if I disagreed with the original report. So there were 103 cases reported as either query 6S or 9S, in other words, query high-grade CGIN or borderline changes. 48 cases were query endocervical dyskaryosis, and 55 cases were borderline endocervical cells. Now, the overall positive predictive value for our query 6S cases, which turned out to be SIN2 or worse, where follow-up was known, was excellent, 91%. The overall original PPV for our borderline cases for SIN2 or worse was much lower at 33%. So this is the cytological review, my review of query 6S cases. And then the vast majority of cases I agreed, okay? Some I would have put myself as severe. Interestingly, I wouldn't have called any of the cases either moderate, low grade, borderline and squamous, negative or unsatisfactory. The PPV, as I said, for these were 91%, which I think shows how good the our diagnostic criteria for our query endocervical dyskaryosis is. Turning to our borderline and endocervical category, this was more variable, and I think this underscores how difficult this category can be. 30% of them, personally, I would have called negative, okay? 8% I would have said was borderline and squamous, 5% was low grade. Interestingly, I would have put some of them as severe, and I only called 19% of them borderline and endocervical, and 6% I would have pushed up to query endocervical dyskaryosis. Okay, but we know that this is a very subjective category, and I might add that when you do an audit, you can be very presidential. It is not quite the same as sort of capturing what it is to do day-to-day reporting. So conclusions and discussion from that. Our query endocervical dyskaryosis category is much more robust than our borderline in diagnosing high-grade lesions, either SIN2 or worse than high-grade CGIN. And when we looked at those borderline endocervical category, there was a range of diagnostic pitfalls, including a range of normal endocervical morphology, including inflammation, which I think might have got overcalled in a number of instances, overlooking are not appreciating endometrial cells, and bland cell dyskaryosis, squamous dyskaryosis. So my final slide. Hopefully from this lecture we've gone over the histology and cytology of high-grade CGIN. I've talked about the cytological differential diagnoses, and I've also described a local audit of the follow-up of query glandular neoplasia of endocervical type and borderline changes in endocervical cells.
Okay, thank you, Tanya. That was a fantastic presentation and some really interesting cases and brilliant images as well. So thank you for that. I know we are running a bit late, but we were delayed from our presentations earlier on, and we do have some questions. So I'd rather, if people don't mind, we'll go through some questions with you, and we'll just go into the AGM a little bit behind schedule. So one of the interesting questions here is, with the introduction of primary HPV testing, have you noticed more HPV 16/other positives in query CGIN in endocervical cells over HPV 18 positive cases?
Thanks, Alison. First of all, I hope, can you hear me? Give me the thumbs up.
We can,
oh,
yes.
For everybody else, it's been a bit of a drama this week about whether I would be able to log in or log out, but thankfully for the 21st century, I'm well and truly in there now. So, okay, so HPV 16 or 18 with high-grade CGIN. As it currently stands, we do not further subtype in the UK with high-risk HPV. So I couldn't tell you which was 16, 18. The rationale for that was when we were first doing a pilot for this, before the introduction across England, it was shown that actually when we followed up women who we then were cytology negative, but HPV 16 or 18, and referred them in to colposcopy ahead of just saying, well, let's give them a repeat, see if the HPV goes, and then send them in later. It didn't actually evidence any significant disease, so it wasn't cost effective. So we don't subcategorize in the NHS CSP in our reports what subtype of high-risk HPV a woman has before we do our reflex cytology.
Okay, that's brilliant. I have another question there. It's more a comment, I think, that with regard to often calling query 9 when we see endometrial cells in women over 40. Is this effective?
I think the recommendations is that you ideally shouldn't, and because the whole point of screening is to look at cervical abnormalities. Now, if you're seeing endometrial cells, obviously that's not a cervical abnormality. So from the point of view of screening, if all the squamous and endocervical cells are normal, you're not seeing abnormality there or dyskaryosis, then I personally wouldn't be using the 9 category for that.
Brilliant. And this one's probably outside the screening program because we already have primary HPV testing, but there is a question there. What do you consider most appropriate to start cervical screening, with HPV molecular test or with cytology?
Okay, so obviously for us, we are now doing primary HPV, but I actually think from a molecular point of view, it makes more sense, because what we were doing prior to the introduction of primary HPV is we were looking at the morphological changes. And then for first, whereas with primary HPV, we're looking for the driver rather than the effect, because we know that a woman, by and large, has to have, in virtually all cases, high-risk HPV on board to drive the pre-cancer cancer sequences. So it makes more sense, to my mind, logically, that we should be looking for the driver first, and thereafter looking at the morphological changes to see if there are any changes that has then produced.
Very good. Just going back to the previous question about HPV 16, other or 18, the author there said in an audit carried out, they found that that was the case. And I have another comment here, interestingly seen similar results in recent BNC and a cervical audit. I don't know if that's relating to that previous comment or not, but that might be the case there.
But
so
we would
that
be
might be interesting.
We would be referring to colposcopy in any case, because we would have seen high-risk HPV positive and endocervical changes.
That's great. So that seems to be all the questions so far. So Tanya, thank you very much for presenting. Really appreciate it. And I'd like to extend my thanks again to all our speakers today. I think it's been a very interesting ASM. Apologies that we weren't able to run this face-to-face. And again, a big thank you and a shout out to all our speakers for adapting so quickly and flipping to an online presentation. We do hope that we will be able to do some slide sessions in the future on maybe webinar sessions with some interesting cases as well. So we will now be going into our AGM.